Welcome to Pediatric Case Review. Today, we present a comprehensive case-based review of Leigh syndrome, designed for general pediatricians in active clinical practice. Leigh syndrome is a severe, progressive mitochondrial disorder that every pediatrician should recognize early. Across this lecture, we will work through 15 carefully constructed clinical cases. We will cover the initial presentation pattern, brainstem involvement, systemic manifestations, examination findings, ocular features, core pathophysiology, genetic causes, neuroimaging, metabolic investigations, treatable mimics, seizure management, dietary therapy, acute crisis management, and prognosis. Let us get into it. Case question 1. A 9-month-old boy presents with a 2-week history of irritability, poor feeding, and loss of previously acquired head control following a viral upper respiratory tract infection. He had been developing normally until 7 months of age. Which best describes the typical initial presentation pattern of Leigh syndrome? Option A, psychomotor regression following an intercurrent febrile illness in a previously normally developing infant. Option B, acute onset seizures with fever and cerebrospinal fluid pleocytosis in a 2-year-old. Option C, progressive spastic diplegia from birth with no period of normal development. Option B, episodic vomiting and altered consciousness triggered by prolonged fasting. Take a moment to consider the developmental history described in this case. The correct answer is option A, psychomotor regression following an intercurrent febrile illness in a previously normally developing infant. Onset typically occurs between 3 and 24 months of age, after a period of normal early development. The classic trigger is an intercurrent febrile illness, which causes acute metabolic decompensation. The hallmark finding is loss of previously acquired milestones, such as head control, sitting, and babbling. Central hypotonia and a weak cry are important early examination clues. What separates Leigh syndrome from a static encephalopathy is the regression pattern, the loss of skills the child had already gained. Case question 2. A 14-month-old girl with known Leigh syndrome is admitted with worsening symptoms. Her parents report abnormal eye movements, noisy, irregular breathing at night, and increasing difficulty swallowing. Which combination of features is most characteristic of brainstem involvement in Leigh syndrome? Option A, upper motor neuron signs, including spasticity, hyperreflexia, and extensor plantar responses. Option B, nystagmus, irregular breathing patterns, and dysphagia reflecting brainstem nucleus involvement. Option C, acute onset unilateral facial nerve palsy with vesicular eruption. Option D, progressive cerebellar ataxia with absent deep tendon reflexes and glove and stocking sensory loss. Think carefully about which structures the brainstem actually contains. The correct answer is option B, nystagmus, irregular breathing, and dysphagia, reflecting brainstem nucleus involvement. The brainstem nuclei in the midbrain, pons, and medulla are prime targets for the necrotizing lesions of Leigh syndrome. Nystagmus and ophthalmoplegia point to oculomotor nucleus damage. Irregular breathing and apnea reflect involvement of the respiratory center. Dysphagia results from damage to the nucleus ambiguus and the vagal motor nucleus. The most important clinical message is the risk of sudden respiratory failure, which is why these children require close monitoring. Case question 3. A 2-year-old boy with a known mitochondrial ATP6 mutation, confirmed Leigh syndrome, is seen at follow-up. His mother reports new onset rapid breathing and poor feeding. Examination reveals tachycardia and a gallop rhythm on cardiac auscultation. Which non-neurological systemic manifestation is most commonly encountered in Leigh syndrome and contributes significantly to morbidity? Option A, renal tubular acidosis with Fanconi syndrome. Option B, hepatomegaly with elevated transaminases and coagulopathy. Option C, hypertrophic cardiomyopathy with metabolic lactic acidosis. Option D, malabsorption with protein-losing enteropathy. Consider which organ beyond the brain has the highest energy demand. The correct answer is option C, hypertrophic cardiomyopathy associated with metabolic lactic acidosis. Cardiac muscle has an extreme energy demand, which makes it highly vulnerable to oxidative phosphorylation defects. Hypertrophic or dilated cardiomyopathy is seen in roughly 30 to 40% of Leigh syndrome cases. Lactic acidosis is defined by a blood lactate above 2 millimoles per liter and can become severe and life-threatening, particularly above 10 millimoles per liter. Additional systemic features include renal tubulopathy, gastrointestinal dysmotility, and failure to thrive. This multi-system involvement signals a generalized mitochondrial energy failure. Case question 4. A 10-month-old infant is referred for developmental concerns. Over 6 weeks, he has lost the ability to sit unsupported, stopped babbling, and appears floppy. Which constellation of physical findings is most consistent with Leigh syndrome? Option A, spastic quadriparesis with brisk deep tendon reflexes and ankle clonus. Option B, generalized hyporeflexia with distal sensory loss in a glove and stocking distribution. Option C, macrocephaly, a large anterior fontanelle, and prominent scalp veins. Option D, central hypotonia, ophthalmoplegia, and loss of previously acquired developmental milestones. Focus on the combination of tone, eye movements, and developmental course. The correct answer is option D, central hypotonia, ophthalmoplegia, and loss of previously acquired developmental milestones. The central hypotonia in Leigh syndrome is axial more than appendicular, with deep tendon reflexes that are normal or reduced. Ophthalmoplegia and nystagmus are key brainstem examination clues. Developmental regression is the most sensitive clinical marker, so taking a careful milestone history is essential. Unlike spinal muscular atrophy, the tone abnormality is central rather than peripheral, and dystonia and choreiform movements may also appear. Regression is what separates Leigh syndrome from a static encephalopathy. Peripheral causes, such as spinal muscular atrophy, show flaccid hypotonia with fasciculations, not this central pattern. Case question 5. An 18-month-old with Leigh syndrome undergoes ophthalmological evaluation. Fundoscopy reveals bilaterally pale optic discs. Examination also shows involuntary rhythmic oscillation of both eyes. Which ocular findings are most characteristically associated with Leigh syndrome? Option A, nystagmus and optic atrophy on fundoscopic examination. Option B, bilateral macular cherry red spots with corneal clouding. Option C, bilateral papilledema with salt and pepper retinal pigmentation. Option D, unilateral ptosis with complete external ophthalmoplegia and meiosis. Think about which findings fit a mitochondrial neurodegenerative process. The correct answer is option A, nystagmus and optic atrophy on fundoscopic examination. The nystagmus is horizontal or rotatory and reflects lesions in the oculomotor nucleus and cerebellar pathways. Optic atrophy appears as pale optic discs on fundoscopy and represents optic nerve degeneration. Other ocular features include ptosis, strabismus, gaze palsy, and retinitis pigmentosa as a late finding. An important distinction: a cherry red spot is not a feature of Leigh syndrome. It is seen in conditions such as GM1 and GM2 gangliosidosis and Niemann-Pick disease type A. Regular ophthalmological follow-up is essential in all Leigh syndrome patients. Case question 6. The parents of a newly diagnosed infant ask a thoughtful question. Why is the brain so severely affected if this disease affects all cells? Which statement best explains the core pathophysiology? Option A, defective peroxisomal beta oxidation leading to very long-chain fatty acid accumulation in myelin. Option B, lysosomal enzyme deficiency leading to sphingolipid accumulation in neurons. Option C, impaired mitochondrial oxidative phosphorylation leading to reduced ATP and preferential damage to high-energy brain regions. Option D, defective urea cycle leading to hyperammonemia and cerebral edema. Consider which tissues suffer most when energy production fails. The correct answer is option C, impaired mitochondrial oxidative phosphorylation. When oxidative phosphorylation is defective, ATP synthesis falls, and anaerobic glycolysis compensates, which produces lactic acidosis. The brain is selectively affected because regions such as the basal ganglia, brainstem, thalamus, and cerebellum have the highest energy demand, so they fail first. The 5 oxidative phosphorylation complexes, complexes 1 through 5, sit in the inner mitochondrial membrane and convert reduced electron carriers into ATP. Prolonged energy failure causes neuronal necrosis and bilateral symmetric necrotizing lesions. On histology, reactive gliosis with capillary proliferation defines subacute necrotizing encephalomyelopathy. Case question 7. A medical student asks which respiratory chain enzyme complex deficiency is most commonly responsible for Leigh syndrome. Which option is correct? Option A, complex 2, succinate dehydrogenase deficiency due to SDHA mutations. Option B, complex 3 deficiency due to BCS1L or UQCRB mutations. Option C, pyruvate carboxylase deficiency, disrupting gluconeogenesis. Option D, complex 1, NADH ubiquinone oxidoreductase deficiency, accounting for approximately 1/3 of all Leigh syndrome cases. Think about which complex is the largest and most frequently implicated. The correct answer is option D, complex 1 deficiency. Complex 1 deficiency accounts for approximately 33% of all Leigh syndrome cases. More than 110 causative genes have been identified, located in either mitochondrial DNA or nuclear DNA. Complex 1 deficiency is linked to mutations such as NDUFS4, NDUFV1, and NDUFS1. Complex 4 deficiency accounts for around 15%, with SIRF1 being the most common nuclear gene. The mitochondrial ATP6 gene is the most common mitochondrial DNA variant at roughly 10%. Pyruvate dehydrogenase complex deficiency is X-linked and is an important treatable subtype. Inheritance may be autosomal recessive, maternal, or X-linked. Case question 8. A 14-month-old boy with psychomotor regression and central hypotonia undergoes brain magnetic resonance imaging. Which finding is most diagnostic of Leigh syndrome? Option A, bilateral symmetric T2-weighted hyperintensities in the putamen, caudate nuclei, and brainstem. Option B, diffuse cortical atrophy with periventricular white matter signal change. Option C, unilateral temporal lobe signal abnormality with gadolinium ring enhancement. Option D, large bilateral subdural collections with an underlying cortical ribbon sign. Recall the regions with the highest energy demand as you choose. The correct answer is option